Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm François Clément Bidard, Professor of Medical Oncology at Institut Curie in Paris, France. Welcome to this program titled 2025 Winter Conference Update, Novel and Emerging Treatment Strategy for Breast Cancer. During this first chapter, we'll be looking at new data on novel and emerging therapies for HR-positive metastatic breast cancer. So we have seen in San Antonio the data from two trials in first line, AMBRE and SERENA-6. AMBRE is a new trial that has just read out and that compared in patients with a high tumor burden, and high tumor burden was well defined with either 2 or more visceral sites or 3 lesions that were present in one visceral site or one visceral site involved plus an elevated LDH. So these patients were randomized between chemotherapy, which could be capecitabine or paclitaxel, or endocrine therapy, which could be an aromatase inhibitor or fulvestrant, both being combined with abemaciclib. So this trial was another trial, but which a very straightforward definition of high tumor burden, comparing chemotherapy to a CDK4/6 inhibitor plus endocrine therapy in patients with an aggressive disease in first line. Primary endpoint was progression-free survival, and the results were really interesting because endocrine therapy plus abemaciclib led to a very long PFS of about 14 months, when chemotherapy led to a much shorter PFS, 7 months. So it's about a doubling in median PFS, which is very significant from the patient perspective. Hazard ratio was 0.67. Overall, the response rate was similar across arms, but the duration of response was much longer with endocrine therapy plus abemaciclib. When it comes to side effect in the ARM trial, there was no new safety signal. Chemotherapy, which could be capecitabine or paclitaxel, came with the usual side effects, hand-foot syndrome, neuropathy, etc., when abemaciclib came with more diarrhea and neutropenia, which is perfectly expected. So again, patients with a high tumor burden now should be treated with endocrine therapy and CDK4/6 inhibitor. We had also the result of a second first-line trial, which is SERENA-6, and these are updated results which come from the second data cutoff. So SERENA-6 is this trial which is testing a new strategy, tracking the appearance of ESR1 mutation during first line, and then patients with an emerging ESR1 mutation were switched to camizestrant plus continued CDK4/6 inhibitor versus staying on the same treatment. And what has been shown at the second data cutoff is now the median PFS, the difference between the two arms is increasing. It is now 7.4 months, so longer than the 6 months that we have seen previously. And we have also reported result on PFS2, which is the time to second tumor progression. Now the delta is about 6 months, so which means the benefit of the switch is maintained at the next line of treatment. And we have also reported time to chemotherapy, which is statistically significant in favor of the early switch to camizestrant with an absolute difference of about 4 months between the two arms. So now let's move to the second line trials. So the first trial is EMBUS-3. So this is a registrational trial for imlunestrant, which is an oral SERD, and imlunestrant was compared as a single agent to endocrine therapy. And the key report here was the overall survival. And we have seen that the overall survival curve are clearly diverging between patients being treated with imlunestrant and standard of care. The hazard ratio is 0.60, so very, let's say, interesting. The p-value is low, 0.004, but it is not crossing the p-value that was determined for statistical significance. There was also an update about the combo comparison versus mono, which is so imlunestrant plus abemaciclib versus imlunestrant in number 3. And at the moment, there is a few events, but what is starting to emerge is somehow a signal with an hazard ratio that was previously 1 year ago higher than 1. Moving to another trial, which is the EVERA trial. So it's a second line trial in which patients were randomized between giredestrant plus everolimus versus standard of care plus everolimus. So it's really giredestrant versus standard of care, and both were given with everolimus. All patients were pretreated with CDK4/6 inhibitor, and we have seen here subgroup analysis for the primary endpoint, so the difference in terms of PFS in patients who had a PIK3CA alteration, yes versus no. And obviously, as it has been previously shown long time ago in the Bolero-2 trial, the presence or the absence of a PIK3CA mutation or an AKT mutation or PTEN alteration had no significant impact on the benefit of using giredestrant combined with everolimus. And they also looked in this study at other mutation, especially ESR1 mutation status, and they confirmed that the benefit would be mostly seen in the subgroup of patients with an ESR1 detected in blood prior to treatment start. So EVERA, to be kept in mind, efficacy is mostly seen in patients with ESR1 mutation, but the status of PIK3CA mutations has no impact. When it comes to another study, which is EPIC-B5. So EPIC-B5 is a new study. So it's a study that we are not aware, before San Antonio. And EPIC-B5, it's a bit of an old study. It compared alpelisib, so it was an alpelisib-based trial comparing fulvestrant single agent versus fulvestrant plus alpelisib in patients who received a prior CDK4/6 inhibitor. So this trial was requested by the European Agency because alpelisib was not allowed in Europe in patients pre-treated with CDK4/6 inhibitor. So EPIC-B5 is showing a benefit, interestingly, in terms of PFS in favor of alpelisib. So this is confirming the, let's say, the added value of alpelisib in terms of PFS. So 7.4 months with alpelisib versus 2.8 months for fulvestrant as a single agent. So it was highly significant from a statistical and clinical perspective. But what is the most striking result of EPIC-B5 is the overall survival, because we have a positive overall survival in this trial, so which is completely unexpected. All prior trials with alpelisib were positive for PFS, but not for overall survival. Here we have a smaller trial, which is about 200 patients that have been randomized. Yet, it's a first trial to achieve a gain in overall survival, but the issue remains that alpelisib is a poorly tolerated drug, we could say. So we know that it comes with a high rate of hyperglycemia, diabetes, and also skin rash. And the safety that has been reported with EPIC B5 is also showing that the safety of alpelisib is not really improving over time. Yet alpelisib is a mature drug, and we know that we have drugs that are much well tolerated. Definitely, capivasertib or other agents that are being developed at the moment. So obviously, I don't see much of a future, even though these data are interesting, especially the overall survival data. So we had also another report when it comes to the testing. That report was on the Capitello 291 trial. And here we had an interesting report about the way ctDNA could be analyzed. And we have seen that overall in this trial that there is a good concordance for PIK3CA mutation and AKT1 mutation between tissue and blood. But now what they are mostly focusing on are PTEN alteration, because we know that PTEN alteration could be tough to detect in blood because it could be like homologous deletion, and this is very difficult to detect in blood. So overall, what they have shown is by using a more performant test, you're able to get a slightly more PTEN alteration from blood, yet tissue would remain the gold standard for assessing the PTEN status in tumor that could be treated with capivasertib if mutated as the second line treatment. So moving then to another trial, so Victoria 1. Victoria 1, we had the first result at ESMO. This trial compared fulvestrant versus gedatolisib plus fulvestrant versus gedatolisib plus palbociclib plus fulvestrant. So it's again a 3-arm trial. And we have a comparison between gedatolisib fulvestrant versus fulvestrant. And that comparison, this update of in terms of PFS was made using different cutoff about the time spent in first line. So which means patients, and they looked at the benefit of the doublet, gedatolisib fulvestrant, versus fulvestrant, in patients who stayed more than 6 months in first line, more than 12 months, more than 18 months, more than 24 months. And what they are showing is very similar to what has been seen in the Emerald trials with another agent, is that the longer the patient stayed on first line, the longer the PFS was in patients receiving the doublet. So which means patients who stayed for more than 2 years in first line had then a median PFS of more than 1 year when they were treated with the doublet, so gedatolisib plus fulvestrant. And this is very much longer than a patient who just stayed for 6 months on first line. So obviously, the first line PFS is still driving the PFS in second line. They have also the second comparison in Victoria 1, which is a triplet versus single agent. And what you could see here is that when it comes to triplet, apparently the median PFS is not increasing similarly to what has been observed with the doublet. So which means apparently the triplet is giving more or less the same PFS, whatever the PFS was observed in first line, when for the doublet, as we have seen previously, the first line PFS is really influencing which patient will have a long PFS in second line. So with that, please continue on to the next chapter, which is looking at the latest update on HER2 positive metastatic breast cancer.
Hello, I'm Mudaffar Maui, the Daniel Duncan Professor of Medicine at the Daniel Duncan Comprehensive Cancer Center at Baylor College of Medicine in Houston, Texas, USA. Welcome to the second chapter of our program titled latest update on HER2-positive metastatic breast cancer. We had several studies presented or updated in San Antonio. We'll start with the HER2CLIMB-05, which was a randomized placebo-controlled study in patients with metastatic HER2-positive breast cancer in the front line. Patients were randomized 1-to-1 to receiving um, maintenance therapy after induction chemotherapy with trastuzumab and pertuzumab plus placebo versus pertuzumab and trastuzumab with tucatinib 300 milligrams twice a day. It is worth mentioning that patients were enrolled in the study after completing successfully their induction chemotherapy with 6 to 8 cycles with a taxane plus trastuzumab and pertuzumab. The primary endpoint of the study was progression-free survival as assessed by investigators, with several secondary endpoints like overall survival, progression-free survival assessed centrally, and CNS progression-free survival. The primary results of this trial showed a clinically meaningful and statistically significant improvement in progression-free survival in the arm that received tucatinib in addition to HP for maintenance over placebo. The control arm had a progression-free survival of 16.3 months compared to 24.9 months in the arm with added tucatinib, with a hazard ratio of 0.64 and an improvement in PFS of about 8.6 months. It's too early to judge on the overall survival for the HER2CLIMB-05. However, with the number of events being lower, the tucatinib arm, it is trending in the right direction, favoring tucatinib, and we will have to wait and see when that data is more mature to be able to draw more firm conclusions. There were no new safety signals with the addition of tucatinib to trastuzumab and pertuzumab. As expected, the addition of tucatinib resulted in more diarrhea, more nausea, and more increase in liver function tests. About 7 to 13.5% were grade 3. Next, we're going to talk about the DETECT-5 study. And the DETECT-5 is a unique study. It randomized 270 patients with ER positive, HER2 positive breast cancer that were first to third line. And the primary randomization was to receive induction chemotherapy versus start with endocrine therapy, both with the addition of ribociclib in the maintenance phase after chemotherapy, or upfront in the endocrine therapy arm or the non-chemo containing arm. It's worth pointing out that the primary endpoint was modified adverse event score. So it was a safety primary endpoint, not an efficacy primary endpoint. DETECT-5 met its primary endpoint with the modified adverse event score being 76.9% in the chemotherapy containing arm and 52.3% in the chemotherapy free arm with a statistically significant p-value. Which is expected. The addition of chemotherapy does result in more toxicity. When we look at the chemotherapy-free versus chemotherapy-containing arm, we notice that the progression-free survival and overall survival seem to be similar between the two groups. And if we look at the tolerability in the whether with ribociclib or without ribociclib, we will see that although the addition of ribociclib resulted in a numerically higher modified toxicity score of 69% compared to 59.2%, the p-value was not significant. However, when we look at the patient outcomes with DETECT-5, we'll see that there was a separation of curves both in the progression-free and overall survival. The progression-free survival was 29.7 months with the addition of ribociclib versus 15.6 months. And the overall survival was not reached for the ribociclib containing arm, while without ribociclib it was 46.1 months. So overall, these safety data argue that the addition of chemotherapy does not help patient outcomes, and it does add to toxicity, while the addition of ribociclib adds to the toxicity, but not in a significant way, at least according to the trial endpoints, and it does improve outcomes. We will next look at the PATINA cumulative incidence of CNS progression or death. Essentially, PATINA is a trial that reported last year in San Antonio and showed that the addition of palbociclib to trastuzumab, pertuzumab, and endocrine therapy in patients who had completed induction chemotherapy with frontline metastatic HER2-positive breast cancer. The presentation of the CNS data showed that the addition of palbociclib to anti-HER2 plus endocrine therapy results in fewer incidents of CNS progression or death. And that was really very reassuring data and quite encouraging. Whether that was true, whether there was a first CNS progression or death as number of events, or the cumulative risk of CNS progression at 12, 24, or 36 months. So the prior slide was all patients. This slide, the patients who did not have documented CNS at the time of study enrollment. The study did allow patients with existing CNS disease, but it had to be controlled. So this is if we basically excluded that small subset of patients, and we still see a similar effect of palbociclib, fewer CNS progression as the first event, and also fewer at 12, 24, and 36 months. So essentially, it was about 13% with palbociclib and 19% without palbociclib, again with a significant hazard. So the addition of palbociclib resulted in a incidence of CNS progression as a cumulative incidence of 13% versus 19.2%, with a significant p-value of 0.03878. We next move to the Destiny Breast 09. As a reminder, Destiny Breast 09, the trial was a randomized phase 3 global study that randomized patients 1:1:1 to the standard of care trastuzumab and pertuzumab added to a taxane chemotherapy versus TDXC plus placebo or TDXC plus pertuzumab. One concern that can come up with long-term treatment with TDXC is the tolerability. And Destiny Breast 09 had robust patient-reported outcome components and reported in San Antonio as well, where the patient-reported outcomes. Shown on this slide is the overall tolerability as rated by the patients on day 1 of every cycle. And as we see here, the TDXC plus P arm in about 52 to 64% of the time, the patients reported that the side effects were not bothersome at all or only a little bit, compared to about 61 to 68% in the THP arm, while and those are reported in green, while in the burnt orange on top, we'll see that about 15 to 19% in the TDXC plus P arm versus 12 to 16% in the THP arm reported those side effects to be quite a bit or very much bothersome. Another important endpoint is the time to deterioration in pain symptoms, and that was measured with the EURTC, QLQ, C30, well documented quality of life questionnaire. And it showed really that there was no meaningful difference between the two arms. The data is still um, immature, with the median time to deterioration not reached in either arm, but the curves look very close to superimposed, and that was a reassuring sign. When we look at GI side effects, however, we noticed that TDXT had numerically more nausea and vomiting, more constipation, and more appetite loss. Please continue on to the next chapter, which is looking at antibody drug conjugates in the early setting.
Hi, my name is Nadia Harbeck. I'm the director of the Breast Center at the LMU University Hospital in Munich, Germany. Welcome to the third chapter of our program titled Expanding Role for ADCs for Early Breast Cancer. We saw some very exciting data at San Antonio this year from the Destiny Breast 05 and Destiny Breast 11 study that were already presented in a presidential session at the ESMO Congress earlier this year. The Destiny Breast 05 was a post neoadjuvant trial looking at TDXT versus TDM1 in high risk HER2 positive early breast cancer, either inoperable and then any non PCR, or operable and then node positive non PCR. And the randomization was 1:1 TDXT versus TDM1. As we all know, the study reached its primary endpoint, and there was an impressive improvement in IDFS and DFS with TDXT over TDM1 with a hazard ratio of 0.47. Now at San Antonio, Dr. Leubel, she showed that the benefit from TDXT was independent of the HER2 status, whether it was 3 plus or 2 plus ish positive. I think that's something that distinguishes TDXT from TDM1 because TDM1 does not work so well in the 2 plus ish positive. And also, about half of the patients had anthracycline containing neoadjuvant therapy before they entered into the trial, the other half anthracycline free, and that didn't really make a difference for the efficacy of TDXT if there was a non PCR after that neoadjuvant chemotherapy. The other interesting data that Dr. Leubel showed us was that the timing of adjuvant radiotherapy, whether sequential with the start of the study or concurrent with the um, study medication, did not impact the incidence or severity of adjudicated drug related ILD in each arm. I think that's a very important message when we take this data to clinical practice. There's also the incidence of radiation pneumonitis by adjuvant radiotherapy, which we actually don't screen so much in clinical routine, but now we need to sort of distinguish that from the ILD that is drug induced. So it's important to look at this in a bit more detail. And patients with sequential adjuvant radiotherapy reported a higher incidence of investigator reported radiation pneumonitis, and most patients recovered, but the unresolved rates were a bit higher with the sequential uh, radiotherapies. But I think the main message here was that it's safe to give TDXT either with sequential or with concurrent radiotherapy. The other study that was revisited at San Antonio was the Destiny Breast 11 study, a 3-arm neoadjuvant trial in high risk HER2 positive early breast cancer, also reported at ESMO in the presidential session. And it looked at patients with large tumors, 5 centimeters or larger, and any nodal status or node positive disease and any tumor size. And there was a small, about 1% um, proportion of inflammatory breast cancer in there as well. The study randomized TDXD followed by THP 4 cycles each versus a standard of care dose dense AC followed by THP, and also an arm with TDXD 8 cycles monotherapy. That arm was closed a bit early due to recommendation of the IDMC. The study had recommended the post neoadjuvant treatment but left it open to the investigator for the final decision. The primary endpoint was PCR, and the study had reached its primary endpoint with an amazing 67.3% PCR rate in the TDXD THP arm, which was 11.2% higher than in the control arm, and that was highly significant. This benefit persisted between HR positive and HR negative disease. And we also had a very early glimpse at EFS, which was not mature at that time, but had a hazard ratio of 0.56 with actually almost a 4% difference in EFS already at 2 years, favoring TDXD THP. The safety was favorable for TDXD THP with a very low ILD rate, less than in the metastatic setting of about 4 to 5% in each arm. Dr. Coriano now presented more detailed safety analysis, and what he did was he looked at the ILD rate per cycle, and what we saw was that actually the ILD rate was quite consistent in the TDXD THP arm, but was higher in the second part of the cycles 5 to 8 in the AC THP arm. The majority of patients had steroids in grade 2 or higher ILD, and majority of these patients recovered. Regarding nausea and vomiting, we saw that actually there was higher use of antiemetics in the control arm, and I think we can get the nausea and vomiting rate down if we also prophylax our TDXD patients properly, like it's recommended in the guidelines. Only about less than 20% had a 3-drug emetic regimen, compared to about 40% in the control arm. So there is room for improvement, and needless to say, in cycles 5 to 8, which is the paclitaxel HP component, the emesis rates were much lower. Regarding cardiac dysfunction, the rate of all grade and grade 3 or higher cardiac events was higher with the standard of care than with TDXD THP or TDXD monotherapy, and there was no events of cardiac failure in the TDXD containing arms. So very encouraging data. With regard to neutropenia, the rates were lower in the TDXD, both TDXD arms, than in the standard of care arm. Then there was a higher use of GCSF in the standard of care arm, which goes with the dose dense application of the anthracycline containing therapy. Dr. Modi presented patient-reported outcome data from DB11 in a separate rapid-fire presentation. And what she saw was that the proportion of patients with maintained or improved physical function during neoadjuvant treatment was higher in the both TDXD arms than in the standard of care arm, which is quite encouraging for implementation of this regimen into clinical practice. Investigators also saw that the patient reported tolerability of the treatment was greater in the TDXD, both TDXD arms again, than in the standard of care arm. With the at the majority of the time points, we see that the quality of life and the treatment tolerability decreases exactly in the week when the cycles are giving, but recovers very fast. And if you look at symptomatic adverse events, the majority of those 20 that were looked at specifically were better with TDXD than with the standard of care. And the side effects that actually impact on daily activities were not could impact on daily activities actually did not impair patients in their daily life. Besides those two studies that had already reported their primary endpoints, there were two posters on exciting ongoing studies with the novel ADC, SAC TMT, and the Trophus 12 study is a post neoadjuvant study looking at patients in the triple negative setting with a non PCR after the keynote 5-2 regimen, and compares a continuation of pembrolizumab with 5 doses of SAC TMT uh, with 12 doses of SAC TMT versus a standard of care, which could be either pembrolizumab or pembrolizumab plus capecitabine. The second trial in progress poster was presented, looked at the Trophus 32 study, which is a neoadjuvant study looking at a modified keynote 5-2 regimen with pembrolizumab plus SAC TMT, followed by pembrolizumab plus paclitaxel carboplatin in the experimental arm, and the keynote 5-2 regimen in the control arm. So I think the data we saw in San Antonio regarding ADCs in the early breast cancer space are really, really interesting, both for the ongoing trials in triple negative disease with SAC TMT, as well as for the detailed analysis we saw from Destiny Breast 05 and Destiny Breast 11. We now have to wait for the approval extensions for both of these regimens, TDXD in the post neoadjuvant setting in very high risk disease, or TDXD in the neoadjuvant setting in high risk HER2 positive early breast cancer. With that, I would just like to thank you for your participation in this activity, and please continue on to answer the questions and follow and complete the evaluation. Thank you so much.